Our moonshot for Marshfield Clinic Health System is to zig when everyone else is zagging and really create a model of care that will work in rural environments. And I think we've hit upon it. And we've really had to approach this in a variety of ways. We've had to expand our acute care. We were a clinic for 100 years, and we realized that in order to deliver our mission and our promise of enriching lives, we had to innovate to develop new care models. We had to extend our efforts way beyond our own walls into our communities. And we really have to leverage the research capabilities that we have and the data to really better understand those we serve and how we can really meet their needs.
Welcome to A&M Healthcare Industry Group's What's Your Moonshot podcast series, where world-class healthcare leaders seek to solve big problems. Listen as we talk to today's health system CEOs about the journey to achieve their moonshots.
Welcome to A&M's What's Your Moonshot podcast, a podcast where we explore how innovative leaders are solving the greatest challenges in healthcare. My name is John McLean. I'm a managing director here at Alvarez & Marsal, and I'm here with my co-host as always, the Honorable Secretary, Dr. David Shulkin. David, I know that you're very excited about our guest today. Like you, she is not only a physician, but one of the most impactful leaders in healthcare. Please join me in welcoming Dr. Susan Turney, the CEO of the Marshfield Clinic Health System. Susan, welcome.
Thank you very much. Welcome to you.
Susan, it's really great to have you with us today. The What's Your Moonshot podcast is all about leaders who have big goals and who are courageous in healthcare. And it's a way to really just talk about what your vision about healthcare is and to share that with other people around the country who are trying to improve our healthcare system. And I know that you've been focused on addressing the problems in rural healthcare, something that's so important. Can you tell us a little bit about what your goals are for healthcare and maybe what's your moonshot?
It's a great question and a momentous day seeing a manned spacecraft take off and land in 11 minutes with 4 newly minted astronauts. So not quite to the moon, but a very impressive flight. I think from my perspective, obviously Marshfield Clinic Health System is a truly rural health system. We have served a rural population since we began over 100 years ago. And in the last couple of decades, we have really seen the systemic issues come into better view and the challenges, obviously, that not just the rural providers face, but the challenges that our patients face as well. And then all of a sudden, the pandemic hit, and it really exacerbated many of the problems that we face every day. One thing, and I know you understand this, David, is that rural communities have patients who are older, sicker, and poorer than people who live in around big cities in the more urban populations. And I think it's important to just put a little data around that because it's a way to really share the stark differences and the challenges that we do face. The median income for a family of 4 in the communities that we serve primarily is about $8,000 less than the state average. And when we think about people living in poverty, 7 of the 9 poorest counties in the state of Wisconsin are in our service area. And we know that, the number of children who go to bed hungry that are living in poverty is a marker of what is happening in our communities. And we have more children on free and reduced lunches than the state average. So if we look at so that's kind of the state framework. But if you look at the national framework, we're actually seeing a very similar picture in rural communities across the country. We know that about 1/6 or about 50 million Americans live in areas where there are healthcare shortages. That's become even much more of a crisis as we're seeing the number of hospitals, the number of physicians, surgeons, paramedics continue to decline over the last 20 years. And we know that 5 out of every 6 rural Americans do live in a healthcare shortage area. And it's not just those numbers. When you think about what people experience from a health perspective, Health Affairs actually did a really great article just a bit ago that talked about children living in rural counties. They have a higher infant mortality rate. They have a higher child mortality rate, and death rates among young adults compared to the urban poors is greater as well. And in many areas of the state of Wisconsin, but across the country as well, half of rural women um, receive their perinatal services more than 30 minutes from their home, and about 10% of those have to drive more than 100 miles to get care. And that's assuming they have transportation, because we know that there is a lack of public transportation many places in the country, but certainly in rural areas, we have very little public transportation. And we know that some of the difficulties our patients experience is the fact that they cannot access care because they don't have the resources to bring them to a community. And telehealth is a solution. I agree, it's here to stay. We've been doing telehealth for over 30 years, yet we have many of our communities that do not have broadband access. And if you don't have access to broadband, it's really quite difficult to have a virtual visit in your home or somewhere in your community. So when you think about putting all these factors together, the mix of the pandemic, rural healthcare, which is a national crisis right now. Our moonshot for Marshfield Clinic Health System is to zig when everyone else is zagging and really create a model of care that will work in rural environments. And I think we've hit upon it. And we've really had to approach this in a variety of ways. We've had to expand our acute care. We were a clinic for 100 years, and we realized that in order to deliver our mission and our promise of enriching lives, we had to innovate to develop new care models. We had to extend our efforts way beyond our own walls into our communities. And we really have to leverage the research capabilities that we have and the data to really better understand those we serve and how we can really meet their needs. And adding hospitals has been, a big piece of this puzzle. When I joined the health system 7 years ago, we had one hospital. Today we have 10, and we have more that are in development. And I know people wonder, why would you build hospitals? It's not where care is going. We need hospitals, and our patients need hospitals, but we needed to right size the hospitals and continue to look at ways to have patients get seen at the best site of care. But we do know that offering that full integrated approach by having the clinicians, by having the hospitals, by having a health plan, a provider-based health plan, we can really achieve that full range of services close to home, and we can really truly have an impact on cost, quality, and efficiency. And we have been able to demonstrate that through many of our programs. So again, the best way to keep most care local for our rural communities is bridging the gaps that exist, providing easy access to care, providing transportation, allowing patients to receive their care at a more regional center when it's necessary, and continuing to stimulate the vitality of our communities by keeping our hospitals open, keeping our clinics open, and making sure that the businesses that exist in those communities have an opportunity to be successful. So we're continuing to collaborate. We're launching many initiatives that really deliver on our promise, improving that patient experience, the outcome, lowering the cost of care. And we're hoping that we do believe actually that we're a national model for what can work in very rural America. Just one other data point, but for people who live in larger communities, we serve about 1.2 million people over 45,000 square miles, and we have only one community where there's more than 50,000 people. Most of our sites are in communities of less than 2,000 people. So it just puts the whole thing in perspective.
Wow. Well, you mentioned the vitality of, your local and community economies. And one question that we have is so stemming from the pandemic, there's even more staffing shortages, speaking of resources, from burnout and just from for different reasons. We have greater needs for those resources and lesser of them. Covering all those miles and in and sort of ensuring the vitality of those communities. I'm sure it gets a lot harder when you probably have, I'm just guessing, lesser resources. How is Marshfield sort of tackling that challenge to, sort of keep down the path of your moonshot?
This is an issue that I'm sure every health system is facing right now as we think about the needs of, providing the services that are necessary for our patients, and especially as we look to expand those services more into the community. But we are finding that workforce really is one of our major challenges right now. And I would say that even though it has been pretty intense over the last several years, certainly the pandemic has worsened the situation that we're in. And I just, again, like to put things in some perspective, because we all are starting from a different place. And when you think about pre-pandemic, there were only about 40 of 180 US medical schools that offered a rural medicine track. Remembering that, a lot of people live in rural America. And we know also that about 90% of final year medical residents prefer to practice in communities with more than 50,000 people. And I already shared that we only have one community with more than 50,000 people. So if you think about the funnel and you just put those numbers in perspective, it's clear that rural healthcare is getting passed over. And then you think about how much worse things have gotten during the pandemic. And actually, even though we had a surge at the end of last year, things did dip down. We're starting to see our numbers go back up. And talked to a colleague of mine in Missouri, and they are obviously being hit very hard by the pandemic right now, and they are having to use a lot of traveling nurses, and they're not able to staff because there aren't enough traveling nurses. And I think about the nursing shortage alone, which is going to continue into the future. If our numbers with inpatients continues to rise, we're stretched right now. I'm not sure where we will get the resource to take care of patients on the acute care side on the short term. But it's also a physician shortage. And, the American Association of Medical Colleges did talk about physician shortages, as many as 120,000 physicians by 2032. That's significant when we think about our aging population. And in general, people who are older tend to be sicker, have more chronic diseases. So you tackle that problem in the perspective of there are more jobs than people applying for jobs across the country. And we know that the number of talented workers in our communities is even less because there's no one across the street. When we have a shortage, we have to go, cast a very wide net to bring people into our communities to help us take care of our patients. And, we're working hard to do this, but we have to, and we have a lot of partners. We have partners with our high schools, technical colleges, our universities to continue to create the pipeline. However, it's just not enough. And we will continue to do what we can for the people that we have, because you pointed out that there is burnout and people have been stretched. People are challenged to take breaks during the day when, surgeries are scheduled back to back, or the, ICU is at capacity. So we're trying to do things to support the providers and staff. We're, providing childcare. We're tutoring children. We're providing wellness and mental health resources. We're doing other targeted support through our foundation, but it just doesn't seem to be enough right now. So we've invested a lot in our people. We've provided a very nice merit increase this year. We've enhanced our benefit package, but people have a limit as to what they can do. So we have to remember to keep this in perspective. And it's challenging because most of our staff, they just don't say no. If there's a patient care need, they stay and take care of the patient. However, it is taxing them. There's no question about it. So we have to think about all of the systemic challenges that we face and address those systemic solutions. But the people problem is a much more difficult challenge to get our arms around. and we'll continue to do everything we can to support our staff and to continue to increase the pipeline. But we all know that that takes a tremendous amount of time, and it isn't going to help us over the next year or two. So we're facing some pretty tough headwinds right now.
Yeah, Susan,
Yeah.
listening to you describe the situation that you face in your communities that you serve, it seems overwhelming. There are so many issues that you're dealing with. And I wonder whether you think about whether these are structural problems that you need to have addressed through legislation and the way that CMS interacts with rural healthcare systems, whether you think it's a matter of providing additional funding to help you achieve your goals. But when you ask for help and you look towards government and public funding, what is it that you think is going to make the most difference?
You know, that's a really deep question, actually, because there are so many parts of what we're doing, or so many pieces of what we're doing that need to be addressed. As I said, there are the systemic issues. I'm not sure that the government can necessarily address the geographic constraints that exist, knowing that we don't have dense populations of people, and they're spread out through a wide geography. But if you think about the opportunity to we know that about 50% of our missed appointments, for example, are because people don't have transportation. And we know that not only can't they afford gas, so we can help them by providing gas cards. We know that if it's an elderly parent, the person bringing them often is someone who has to leave their job and doesn't have paid time off. And in many circumstances, they're bringing smaller children with them because they don't have anyone for childcare. So when you think about how the government can help, I think the support around critical access hospitals, rural health centers, around other funding that CMS has provided has been very beneficial to our organization, but a lot of our challenges extend beyond the facilities that we provide, direct hands-on care. If we, we want to continue to expand our network of hospitals across the state and make sure that we make it easier for people in these small communities to really access care. And I already mentioned telehealth. I mean, we've been doing telehealth for over 30 years. It's a critical tool. Fortunately, in many ways, the pandemic did shine a light on telehealth. However, the uncertainty about how this can be, or not how it can be used, but when it should be used and how it will get reimbursed is still unknown. And we think we have the right infrastructure. We think we understand how to take care of patients. And we think that the regulatory framework really needs to support that. As the technology continues to expand, we need to face these issues head on. And it shouldn't be a political battle. It should be what's right for the patient. And even creating a digital front door, for example, I mean, the consumers have changed so dramatically during this time. So we need those resources to better, or to allow our patients to better navigate, to have the tools at their fingertips and the solutions that they need to really manage their care. I mean, even during the pandemic, and people didn't have the ability with broadband to be virtual on video, many had a smartphone in their hand and they were able to communicate and have many of their healthcare needs addressed during that time. So as we shift from the traditional healthcare into the different models of care, uh, the payment mechanism has to catch up with the way we deliver care. And I realize that just another example that I would share is we've had a well-established hospital at home program, very successful. We've delivered on our promise of lowering the cost of care. We have high quality, high safety, and the patient experience is better than those who have an inpatient hospital stay. Getting your care in your bedroom or in your living room is much better for people than having to be in a hospital unless a hospital stay is necessary. So when you think about that, it's kind of intuitively obvious that as we think about the best way to take care of patients, reimbursement should follow. But it's been a huge challenge. And our health plan pays for the service. Now, some other national payers are considering it, as is the federal government, beyond the pandemic crisis. So it's really having the government keep up with this rapid pace of change and making sure that we put the patient first.
That's such great insight, and I wonder if maybe we could close, Susan, with some. We've talked a lot about the challenges, many of which, like you said, are systemic that we face in the rural part of the country relative to access to health. But I wonder, based on your career um, as not only a physician but now as an executive in that space in the country, what advice would you give to your colleagues across the country um, relative to successfully going into rural health and providing better access that is affordable?
Mhm. Yeah, you know, absolutely. I mean, we know that rural health care has systemic issues, and it will require systemic solutions. And we know that we can't address all the obstacles that exist right now. So I think the important thing is to remember that we do need to work with partners. We have to work with people within our communities to help serve our patients. We have to work with our state and our national elected leaders and really other like-minded industry groups to really collaborate on the biggest challenges, that we have. I do believe that when we do view the world differently than others, and we do know how to make it work, but we can't live solely in our legacy. We must do that fundamental transformation to meet our patient care needs, and it requires an investment. But when you see the need and you see the opportunity and you're attracted by the mission, I think it's much easier to get that collaboration across entities to really really do that service.
Yeah, we sort of started to see your point about partnerships as a common theme across the country when we talked to your colleagues who are, deploying similar moonshots. It's, they say we can't go it alone, right? We have to partner with our colleagues, whether they're local or global or whatever. And listen, Dr. Turney, we just want to thank you. We appreciate you taking the time. We're inspired by your moonshot. We're behind you 100%. And thank you for joining us today.
Well, I appreciate it very much. It was fun. I hope it turned out okay.
Thanks, Susan.
Great.
Appreciate it. Thanks for the time.
Yes.
Take care.
Okay,
Bye-bye.
bye, David.
Okay,
Thank you.
Thanks. Thank you.
Alvarez and Marcel. Leadership, action, results.
So, John, I think that our listeners today are really going to enjoy hearing from Dr. Turney. She has a really tough job trying to lead an organization that has both a health plan, a provider system across so many communities that are truly rural.
It was sort of amazing to me to hear her quote. I mean, so much of the great data that she alluded to, but in particular, I think it was 45,000 square miles of coverage. I think that was the number, right? 45,000 square miles.
Yeah.
Yeah, that is, I mean, to sort of being the predominantly the sole provider in a community that's so expansive, when you are faced with challenges like lack of resources, lack of bandwidth and broadband, it just seems so daunting. And but they're tackling it head on, and it really is inspirational.
Yeah, I think that's the right word, inspiration. When you listen to her, you see that passion of a physician leader that knows that they are given a really tough situation, but that they're not giving up, and her determination to overcome many of the structural issues and societal issues, I think, really gives you the hope that she's going to be able to do that and that she is making a big difference in her communities.
So what's so interesting to me about the strategy that they've deployed as they've built their infrastructure to more adapt to rural health, they've actually had to add hospitals and add acute beds, which is sort of, I don't know, the inverted version of the strategy that you see other health systems deploying. And in large part, it seems like because that's a direct reflection of what the community needs, right? The community needs in those sort of more rural areas, potentially acute beds.
Well, I think that's right, John. And I think that's the real policy issue that so many people have been dealing with is the critical access hospital the right model for rural healthcare? Clearly, there needs to be some type of presence in the community, and particularly where it would take so long to be able to reach the help that people need. But the structure of the critical access hospital has been one that's been generally inefficient and expensive to maintain. So I think that the rural healthcare systems of the future are trying to think about how do you find that right balance between virtual and physical care?
As you think about, and Susan alluded to it, both sort of the catastrophe that is the lack of access in the rural setting and the not the ever present and continuing to get worse issue and challenge of shortages in staff relative to clinicians and providers. And it's to your question earlier, David, you wonder how the government can help with that infrastructure, both in terms of whether it's, broadband in the rural setting, to your point, better support for critical access. But also, what are we going to do to create a workforce that is for, especially for RNs and for physician providers, strong enough and big enough to take on the needs in the rural health setting, and for that matter, more broadly across the entire country, all clinical settings.
Yeah, John, I think if there's ever an issue that really requires public-private partnerships, it's going to be addressing the rural healthcare needs of our community. And we didn't even talk a lot about the behavioral healthcare needs in rural America, but
Yeah.
that's significant as well. But the good news is that this is an issue that I think that there's bipartisan support on. There's enough people who are in public office that understand this issue, that come and serve rural communities. And when you have leaders like Dr. Susan Turney that are outspoken and strong advocates and articulate about the issue, there are the right partners between the private sector and those in government to find solutions.